Right. So I will be talking about platelet-rich plasma in tendon injury. Okay. So basically, I'm a joint replacement surgeon, and I do like to publish, and I'm huge interest in academic. So this recently we published our own technique for joint replacement. This is with the name of Yadav and Ashok technique. This is one of our book. Now for the last 7 years, I have also interest in regenerative medicine. This is one of the paper which we published to describe how stem cell are working in osteoarthritis of the knee. This is another review article about covering what is the status of all the regenerative product in the current situation for osteoarthritis of the knee. Then another review article about the PRP, what is the hope, hype, and how it helps in osteoarthritis. And recently, last week, this has been also published. Now the regenerative medicine is also helping the COVID because we are getting information from China, from UAE, and some other country that the stem cell is helping in severe COVID infection by fighting against the cytokines and helping in early recovery and reducing the morbidity. So today my talk is about how the PRP is helping in tendon. As we know, the tendon structure is more like a nerve. So you have these fibers, then you have primary bundle, secondary, and then you have complete tendon. Now, in a tendon, the amount of cells are less. So basically, it's a low cellular density in the tendon. And the main cell is the tenoblast or tenocyte, which constitute 90 to 95% of all the cells. They also have synovial cell, which are usually present in the covering of the tendon, and where the tendon is inserting over the bone or any epineuritic junction, they also have some chondrocyte and of course some blood vessels and of course some nerve cells. So what happens when there is a tendon is abnormal, the many changes might happen. It may lead to either like the collagen fiber, they may be disorganized, the cell content in the tendon may be more, or the tenocyte shape might also be altered. There may be calcification, fat deposition, or so this is a normal tendon, how it look like, smooth, glistening, and less cells. And here how the tendinopathy look like with increased cellularity. Now, tenocytes are actually more like fibroblasts, and they are differentiated, and their main function is to do synthesis for the extracellular matrix for the tendon. They are usually found along the collagen fibers. And if there is a pathology which is affecting the tendon, it usually leads to fibrochondrogenic transformation, like fibrosis is there, and some immature cartilage may also form. Extracellular matrix of the tendon consists of different kind of fiber like collagen and elastin. Majority of the collagen is type 1. When the degeneration start, the amount of type 1 collagen start getting less and the amount of type 3 collagen start becoming more. Collagen is responsible for the tensile, the resistance against the tension. Then they also have the elastin fiber, which are responsible for stretchability and flexibility. And of course, they have ground substance like proteoglycan, which is responsible for viscoelastic property. In the tendon healing, the first phase is phase of inflammation, and there it is followed by proliferation, consolidation, and maturation. So what happened in the inflammatory phase, these inflammatory cells are involved like neutrophils, monocyte, And the main role during this phase is the mesenchymal stem cell, which are derived from the circulation, like from the blood. And of course, you have different growth factors. During the reparative phase, when there is more proliferation, there is a activation of the local tendon stem cells or progenitor cells. And with the help of the growth factors, the reparative process starts. During the remodeling, the type 1 collagen increases and type 3 become less. And then you have these growth and differentiation factor which helps in remodeling. Now there are various growth factors which are involved, which have been used or which have been proposed to treat tendinopathy, and they are synthetic, some are endogenous. Usually they are like fibroblast growth factor and BMP, then platelet dry growth factor which help in healing, and beta transforming growth factor. So if we see in the PRP, you have almost all of them, VGF, beta, IGF, but the BMP is not there. Usually whenever there is a tendon injury or degeneration, the healing happen by two ways. Either it is extrinsic healing, that the cells from the outside in the form of fibroblasts or the mesenchymal stem cell, they come up. And also from inside, from the endotendon, there is a more migration, proliferation, new vascularization, and remodeling. And once the tendon is healed, the tendon strength is a little bit less, and the ratio of collagen 3 by collagen 1 is high. Now, as we know that in different part of our body, you have stem cell, same way you also have stem cell in the tendon. And these are called tendon stem cell or progenitor cells. They usually remain quiet under normal physiological condition. But whenever there is any stress like a mechanical factor or there is any trauma, then they get activated. They also get reduced with the age, and they are able to differentiate in all the three lineages. They can form bone, fat, and the cartilage. Now these stem cells, they reside in a niche. As we know, the stem cell need a environment in which they can survive. Usually they are in the perivascular space, and they are regulated by the BMP and proteoglycan like biglycan or fibromodulin. Now, in the tendinopathy, the most commonly we see two tendinopathy. One is the tennis elbow, and then we have the rotator cuff. Now, in tennis elbow, usually it's a misnomer because it's not related to the tennis. Majority of the cases, they are non-athlete. So whenever there is a repetitive concentric loading of the muscle, then the degeneration starts. They have been given in the past various names like Reiter cramp, lawn tennis, and as I said, they are more common non-athlete and they are more common in the dominant arm. So main problem, the current concept is that there is a micro tear in the tendon origin of extensor carpi radialis brevis, which lead to the tennis elbow. There are different stages have been described, whether initially it's just inflammation or there is an increase in the thickness of the tendon. When more than 50 is increased, it's called 2. And when less than 50 is called 2. And when more than 50, it's called 3. And when there is a rupture, that is called stage 4. Usually when there is a rupture, it needs surgery. Now during initial stage, we try these like, this is called price, in which we add medicine and different modality. Now, before the standard treatment was the corticosteroid, and it is usually given, it should be, before we used to give, now we are giving PRP, but if somebody is giving steroid, it should never be given inside the tendon. It should be around the peritendinous region. And there should be interval of at least 6 weeks between the two injection. Don't give more than 3 injection at one site. There are many side effects when we give corticosteroid injection. The most commonly we see the skin atrophy and hypopigmentation. If you are giving repetitive injection or inside the tendon, there may be atrophy and there may be tear or there may rupture. If there is any local infection, tendon tear, young patient, they should not be used. This is a picture showing the crystal formation of the medicine who received more than around 12 injections for this tennis elbow. So now we'll discuss how PRP is helping in the tendon disorder. So actually it has been shown that the PRP has a synergistic effect with the tendon stem cell or progenitor cell. So PRP, we know that they have growth factor, and in previous slide we have seen those growth factors, they help in the tendon healing. So PRP also help in differentiation of the tenocyte towards the tenocyte, not towards the non-tenocyte. They also help in gene expression, and they also help in increased production of collagen 1. Is there any evidence? Well, these are the latest study and I put them in the table. So this is basically the latest systemic review and meta-analysis published in 2018, and they just included the level 1 study. There were 21 studies, and they show in the result that the short-term result and the long-term result, it reduces the pain. But this reduction in the pain work only for tennis elbow and the rotator cuff. Then another article is by Eric Chakran in 2016, and they also included randomized control study. There were 10 study, and it shows basically they compare PRP with the steroid and also with the autologous blood. And they found that the PRP is better than the autologous blood, and autologous blood is better than the steroid. When you use the whole blood, then the pain and swelling is more in comparison to the PRP. So it reduces pain and it reduces and improve the score. Then another study in 2014 by Morris, they included 19 study, but not all of them were level 1. And he suggested that there is no difference between PRP versus alternative therapy, whether you use physio, whether you use saline or any other conservative. Then Rath used another meta-analysis they done in 2015, and they included both level 1 and level 2. And they also found that if you were using PRP in a arthroscopic repair of full tear of the rotator cuff, when you apply PRP at the junction of tendon to the bone, it helps. But when you apply over the surface of the tendon, it doesn't help. And there's no statistical significant difference between the overall outcome or the re-tear rates. Now we come to the another two common tendinitis is the patellar tendinitis and Achilles. And I again put them in the table. So in 2019, the Alex did a randomized study, and they basically did on 57 patients on each group, chronic patellar tendinitis, and they found that there's no difference at 12 week or after. Another study in 2017, they basically did a systemic review. They included 15 study, and they found that if you use PRP or shock wave, either as a main or as an adjuvant, it helps in the early recovery. And the steroid, they should not be used. For the Achilles, DVOs have done randomized study, 54 patients, and they found there's no difference on ultrasound if you compare the thickness of the tendon or the density of the tendon, and there's no difference in the score. Another meta-analysis by Liu, and they also found there is no difference. So we can see the literature show that there is an improvement if you use PRP for patellar tendinitis, tennis elbow, and rotator cuff. But for the chronic tendinitis, degenerative, Achilles tendinitis doesn't help. Now these are our patient. This is a 23-year-old male patient having Sinding-Larsen syndrome, and patient was having constant pain in the lower part of the patella where the attachment of the tendon is there. He was not able to fully extend the knee. He was not able to do running or do some sports activity. and there are slight irregularity in the tendon. And this is the transverse section and ultrasound, how it looks. So in this patient, I use leukocyte-rich PRP, 3 injection at weekly interval. So this is the way the needle directed at the attachment of the tendon over the patella. And on the axial section, this is the needle, and then we inject under ultrasound guidance. This patient, when you inject inside the tendon, the PRP, it's very painful. So for first 1 or 2 days, the patient has a lot of pain. We usually recommend ice application. We don't recommend any non-steroidal anti-inflammatory because it will act against the PRP. So 1 gram Panadol or paracetamol 12 hourly for 3 to 4 days. Then usually the effect come around 3 months and the patient was able to resume the full extension, started jogging around 3 months, still not playing football because I'm putting him is more on strengthening of the quadriceps, and on your hamstring is also tight because he was not extending for the long time, so he's working on his hamstring. This is a 15-year-old child who is having Osgood-Schlatter disease, and on X-ray and CT, there was still some translucency at the junction where the tendon come and attach. But in this patient, because there was a translucency between the parent bone and the tibial tuberosity, I combined both PRP and BMAC under fluoroscopy. And he is doing well and he is playing football. Before, he was not able to do running. Another patient with tennis elbow for 6 months, failed treatment, failed physiotherapy, and he tried depot also, steroid didn't work. So in this patient under ultrasound, I gave single injection, leukocyte rich. So this is the area in it, you pass the needle, subepineuritic area. This is the needle, and then you inject under direct vision the leukocyte rich PRP. This patient did not show any improvement for first 2 weeks, and around 3 months he started showing good result, and now he's playing. We can also use it for shoulder. Usually the patient, they come with the biceps tendinitis, like they see some white, you see this white edema fluid collection around the tendon. Sometimes you also have changes in the bone also. So in the shoulder, like this patient, 28 with supraspinal tendinitis, biceps tendinosis. So under ultrasound with the needle, we first go for the biceps, then for the rotator cuff, then also at the attachment at the end plate. And again, the improvement usually come around 3 months of the full result. After in just second injection, they have some improvement. So this is the talk about PRP. PRP has a role in the tendon. Literature is there with good evidence for tennis elbow, for patellar tendinitis, and for rotator cuff. Achilles tendinitis is still not good literature. There are some study which who combine PRP with the bone marrow. This is my email. If you have any question, you can contact us. And this is the YouTube channel through which this we are conducting regular webinar, which are free from any commercial interest. So now I'll stop sharing the screen. Are there any questions? Okay, so let's see the question. So the question is, the PRP local injection is very painful after the injection. How you manage? Any role for xylocaine? Well, actually, we don't mix the xylocaine with the PRP because then it might change the pH of the PRP. It might change the character of the platelet. But what we can do in some sensitive patient, we first put lignocaine only in the skin and just below the skin to make that area numb. And then through that, we go for the injection. Post injection, we manage, I already explained, with the Panadol, ice fermentation, And if the pain is too much, then we give tramadol. We don't give NSAID.